Okay, our presenter today is Sandy Atkins. Sandy is Executive Director of Hospice of Pasadena and has worked at Partners for 11 years. She leads Partners' nationally recognized Home Meds program and works closely with Partners CEO, June Simmons, to provide strategic guidance to the organization. And with that, I'll turn the floor over to Sandy. Welcome this morning, Sandy.
Good morning. Hi, how is everybody? So I'm going to be moving the slides and talking a little bit about the Business Institute. And then before I get started, I just wanted to correct, I was Executive Director of Hospice of Pasadena until it was sold in 2006. And I've been at Partners in Care Foundation as a kind of everything that there is to be done in the organization. Currently, I'm going a little bit toward part-time, and I'm a strategic initiatives advisor, and I oversee the Home Meds medication management program nationally. So I just wanted to kind of put that in there. So the Business Institute was initially funded by the John A. Hartford Foundation and the Administration for Community Living, and has involved a number of organizations, including ASA, of course, the SCAN Foundation, Elder Services of the Merrimack Valley, Independent Living Research, and 4A. So let's move that along. So we have basically, and I'm saying we because I've been involved in this, actually we had a precursor grant from the John A. Hartford Foundation that turned into the Business Institute. So I have a very we feeling about it, even though I don't work for N4A. So there are learning collaboratives for advanced business acumen skill, and this is basically funded by ACL. And that's organizing learning collaboratives to go beyond the kind of the elementary just getting started in contracting to moving beyond. The trailblazers are folks like us that have been doing contracting with healthcare organizations for, we're like at 11 years or so ourselves, and others are also more advanced. And so we're kind of using ourselves to push the field forward, and then trying to produce information that will be helpful to the other people that are just getting started or not quite as far along. There's a health information technology learning collaborative trying to put together some pathways for figuring out what to do with health information when you're in collaborative arrangements with healthcare, kind of bridging between social services, case management systems, and what goes on in the healthcare organization, and how we can work together on those things. And then most recently, a Medicare Advantage learning collaborative that is looking at the special supplemental benefits and other motivations within Medicare Advantage plans to have them contract with community-based organizations. And Partners in Care Foundation is a community-based organization, so I say us for that. And the whole idea is to keep on evolving curricula for those that are interested in moving into the domain of contracting with healthcare. So the Trailblazers Learning Collaborative was to develop comprehensive strategies for approaching and engaging healthcare payers and providers, and then to develop and test roadmaps, which I would more call toolkits or tools. And there's two work groups within that, one for health plans and one for health systems. And those two groups have essentially what we've divided into is health plans work group is more looking at tools for standardizing scopes of work, for measuring outcomes, measuring patient engagement and experience. And the health systems work group is more on that roadmap path and putting together tools for judging, who are the players in your world and who's ripe for contracting and what's your competitive environment, things like that. So the N4A did a kind of a baseline survey to support Miami University's evaluation for the John A. Hartford Foundation to show that they were actually having an impact on the industry. So between 2017 and 2018, 2017 is the light blue and 2018 is the darker blue, that the percentage of respondents and the number of respondents went up, I believe, but in addition, the percentage that say, yes, we currently have one or more contracts went up from 38 to 41%, basically. No contracts but pursuing stayed the same, and no contracts but not pursuing is sort of the reciprocal of, yes, currently have a contract. So in essence, the field of, the group of CBOs that are pursuing contracts is growing and, soon approaching half of the organizations. I assume that questions go for the end, so I'm just going to plow through here. I don't mean to ignore all of you out there listening in, but this is the way that it's set up, I believe, for the whole shebang here. So what we're looking at now is, who are CBOs achieving contracts with? And Medicaid managed care organizations is the leader, and again, the dark blue is the more recent data, so that's growing. As states get into managed long-term services and supports, and the expansion of Medicaid continues. State Medicaid that isn't a pass-through, again, growing. Hospital or hospital system, it's actually shrinking a little bit, though, we've been growing our contracts in that area. I think that was sort of the post-CCTP drop-off a little bit. VA Medical Center, that's growing. Commercial health insurance, that's growing. Duals plans growing because, all of that is, so every kind. So you can see in order, possibly take this as somewhat prescriptive, that the most likely success is going to be in managed Medicaid and state Medicaid and hospital systems, VA, and then decreasing but in total number of contracts, but increasing in representation in those contracts are commercial ACOs, fee-for-service Medicare, Medicare Advantage. So I think Medicare Advantage is going to grow a lot pretty soon. The most common services, case management, care management. I'm seeing that, I'm just going to say almost everything is growing. The only thing that diminished in this time span was, I guess nothing was diminished. So as a percentage of contracts, all of these are increasing. Care transitions, discharge planning, that kind of goes along with contracting with health systems. That's grown a lot. Assessment for long-term services and supports, that's really leaps and bounds. Nutrition, evidence-based programs like chronic disease self-management, matter of balance. So I'm not going to read through the whole list. That's kind of boring. You'll have the slides. You can study this more as you go along. So I represent the health plans. I've been chairing the health plans work group since it existed, so 2-3 years. And we're going to introduce the LTSS Client Experience Survey, but I'd like to give you a little bit of background on Partners in Care and how we got into this and why I'm interested in it and have been kind of harping on this. So our first contract this is one of my big lessons learned in contracting, which I give away for free no matter what webinar I'm doing, which is don't give a final price until you've seen the contract. Because what we found after we had pretty much said, here's our price, and we were babies at the time in doing this kind of work, was that they wrote into it that we had to pay an outside entity to do patient satisfaction surveys or member satisfaction, as they would call it in a health plan. It's always a member, not a patient. And so we had to get an outside evaluator. We eventually talked them into letting us have a separate department from the department delivering services to do the surveys ourselves, so we could do it more cost effectively. So that was one thing. So they immediately wanted some measurement of quality and I wouldn't say outcomes, because it's not asking people if their lives got better. It's asking if, they got good service. And then in addition to that, they, I believe at the behest of our California Department of Managed Healthcare, told us that we had to become accredited, NCQA accredited. Now, today there is an LTSS, Long-Term Service and Supports, accreditation available from NCQA. At the time there was not, so we were accredited for complex case management under the same rules, regulations, and standards as health plans. So we had a kind of quite a journey there, translating what we do into health plan ease and kind of making sure that we could do that. But again, what that set in motion was an entire department in our organization circled around quality, setting up all kinds of quality committees, evidence committee, a quality assurance and performance improvement committee, engaging the whole organization. And so doing client experience or patient experience or member experience surveys are all part of having an ongoing quality improvement process that is absolutely necessary as you get into the domain of contracting with healthcare. So when the health plans work group, so again, remember that this is the trailblazers. These are people like Elder Services of the Merrimack Valley, the folks in Indiana, Direction Home in Ohio, and ourselves. We were talking about, so what are the challenges that remain for us? We've conquered all kinds of territory, but it's not easy still, and we can say we have a contract, but then you look at it and you've got a contract with a health plan that has 2 million members and you're seeing 500 a year. That's not exactly what we had in mind. We thought that, that there should be kind of population-based, and instead they were, doing referrals from individual case managers, and depending on how engaged and convinced they were that we could do a good job, they might or might not refer people. So the group was talking about, okay, so what are our biggest challenges now? And that one, volume, was one that we all shared. And the other one was that we have contracts, but we can't build a good business proposition because they do not share data with us. So what can we do to basically do an end run about the fact that they don't share data? And I don't think it's because they're necessarily not willing to share data. I think that they have they have to report to all kinds of people, and their IT and analytics folks are very engaged in other work, and that we kind of fall to the bottom of the list. So no matter what the cause, we only have very few partners. UCLA is one of our partners that's been really great. I had a meeting with them once, and they said, we want to see population level outcomes, show us the data. And these are brilliant people, MD, PhDs, and I had to say, you have the data. We don't have it. And by the next week, they had data showing that we had brought their population level readmissions in the high-risk group down 3 percentage points, and that the intervention group had reduced readmissions from 30% to 10%, which is a 66% reduction in readmissions. They have been a wonderful partner for us in helping us build our value proposition and be able to show our results in Medicare Advantage and in Medicare fee-for-service. But we have many other contracts and seldom get any data from them. Sometimes the QIO, the Quality Improvement Organization, which in California is Health Services Advisory Group, if they get permission from health systems, hospitals and health systems, they can do analytics on outcomes, particularly related to readmissions, which is one of their main goals. And so we have gotten readmission data from the QIO, which I highly recommend you try to do. But the hospitals have to give permission. They can't give it out to anybody. The hospital says, yeah, share my data, and then it happens. So the fact that many of the leaders in the initiative of getting contracts with healthcare say, we don't have much of a business case to provide to people because we don't get the data. We just decided to take the bull by the horns and say, okay, well, if they won't give us data, we'll produce our own data, and we will. So then we got together, and the first step was to collect all the surveys that the TLC, in addition to meaning Tender Loving Care, means the Trailblazers Learning Collaborative. So it's like TLC squared for us. So we collected all the LTSS client experience satisfaction surveys that we were doing. So, we used our waiver program surveys that we have to do for the state. Others had longer-term MLTSS, Managed Long-Term Services and Supports, MLTSS plans in their states. So they had a track record of questions and answers and were trending. And then we scanned other measures, especially those from recognized authorities, such as CMS putting out their health plan surveys, and those recognized in the healthcare sector measures, like PHQ-9 is so standard that it's almost not worth worrying about how else would you measure depression, because that's what's recognized. So because we're trying to convince healthcare to use our services, if we're going to do a baseline and change in depression, we're going to use PHQ-9 because they understand it. Then what we did was map commonalities within all of these surveys. An issue that sort of came up was that if I have a 5-year history of satisfaction data and we're now trying to standardize it and you're using a different scale or a different question, how do I integrate my data? Am I going to really be able to participate? So, well, we tried our best to get the best of all worlds. So we put together all of the questions, then we started whittling away at them and getting rid of, well, this is nice, but I don't think it's going to be convincing to anybody, so let's leave this one out. Then we refined the question order, wording, and answer sets. So Scripps Institute has been helping us with all of the measurement aspects of the Business Institute. And so what they recommend is if you've got a certain answer set of small, medium, and large, group all of the questions that use the same answer set, because otherwise you have, it increases the survey taker burden. And then making sure that the wording is super clear, and then to the extent possible have a logical progression in thoughts and group questions together by what they're referring to. So if you've got questions about services and then questions about case managers, try to put those in order so that you're not, getting mental whiplash from switching to case manager to program to something else all the time. So then we piloted it ourselves internally, revised some of the questions, and have been rolling out the survey. Why are we doing this? There's three uses that we talk about. One is, of course, to continue our internal quality improvement. The second is so that we can start benchmarking we consider ourselves an industry. So how am I doing compared to Elder Services of the Merrimack Valley? How am I doing compared to Direction Home or all of the other folks doing this work throughout the country? And then finally, for our external reporting, so we provided the report that I'll be showing you to our state Medicaid agency and California Department of Aging, who are the two overseers for our Medicaid waiver for older adults, and they thought it was fantastic. The people in our organization said it was much easier to administer, and I think for the first time they got no complaints from clients about the survey and how long it was and how hard. We had a better response rate, all of those good things. In addition, this supports NCQA accreditation, so you have to keep showing how you're doing better and better at measuring and improving. You're improving your improvement. And then to support sales by building a national business case. So our thought was that if we get a number of organizations throughout the country and we can show fairly similar levels of patient experience, satisfaction, and outcomes, that it would support others getting into the business by saying, well, here are these 6 organizations or 10 organizations doing what we do have had these outcomes. There's no reason to believe that we wouldn't, and people can start claiming that as their own. So those were the reasons we decided to get into this. And, okay, I'm watching. One of the important things that happened after we had started, and we were probably 3/4 done, and then CMS released the CAHPS case management questions for home and community-based services, and I provided a link there because it's a big survey that includes satisfaction with individual services like transportation, personal care, those kinds of things. We decided to start with just care management, case management, because that's what our contracts with health plans were centered around. But you can pull from that. It's a standard measure. You talk to anybody in the healthcare world and say CAHPS, and they immediately, feel like you're closer to being in their world. NCQA, accreditation, CAHPS, those are all vocabularies that put us in their world rather than as these odd, fluffy social service strangers on the outside. So we highly recommend adopting measures that are those standards and also using those words. So as you can see there are a lot of domains other than the case management domains that we chose to use for this survey. Now this, I'm sure, is very small on your screen. So what this was in the results, we looked at one organization that had put the most data in the system and plotted their scores by case manager. So this is for internal kind of benchmarking use, just to show some of the potential uses of the survey internally. So although you can see on a 5-point scale, there aren't any really low scores, you can see that there are the best of the best are, Patricia or Patricia probably and Manuel, and the ones that are maybe a little bit less, more less outstanding, shall we say, since everybody is fairly positive, are Richard and Maria A. And that, you could set up Patricia and Manuel as mentors to Richard and Maria, for example. So it just shows you, and if you're doing your performance evaluations, you would say, the two highest performers get extra points, and the two lowest, they might get an okay but not an outstanding score on their performance appraisal. This is another way to use the survey. So all of the questions in the survey are on the left. If you're curious about what all the questions are, you can get out your magnifying glass or expand your screen and take a look at them. But it shows, so here we've got two organizations. Now if you look at the ends, the Site 1 had 10 cases entered, and Site 2 had 10 cases, and Site 1, the blue one, had 195 cases. So, and I think among those 10, there were probably some test cases, and who's going to enter a test case that isn't wonderful, huh? Anyhow, so you can see that on this graph, if they were really, sort of equivalent, you would say that Site 2 is generally much better than Site 1, and that Site 1 would want to try to improve its performance so that it could benchmark more positively against Site 2. And so we would pick the ones where there's really, okay, where did we really fall down? Did your service plan include all of the things you needed? And we'd try to look, go with then and dig into it and find the comments. Well, what did you need that you didn't get? And see if we can find out if, the individual case managers made a difference, or if it's in general, like our waiver, we've been dealing with 1987 rates since 1987. Maybe it's just because you're constrained, but perhaps it's because you're missing some opportunities to close the loop with people and make sure that you understand what they want. So there's a whole quality improvement thought process that goes behind each question once you pick something as a quality improvement project that you want to address. And so that lets us benchmark against other outstanding people in the country. So this is another way we get information out of the system. You can look at it as a pie chart on an individual question about the overall responses. So this one was, how often did the case manager consider your preferences? And so usually, always is obviously the preponderance, and you've got, don't know, we're going to leave that out. Unclear response, we're going to leave that out. Never is less than 1%. You would want to find, that's where you would hope to have contact information for the person and follow up, like, why is this person so unhappy? And then likewise with the sometimes, because our standard really is that you're always considering preferences. So this just lets you target and see where the patterns are in a particular question, as opposed to all of the questions and the general results. This is basically the same. How often does the case manager treat you as you want? So that's even more, more always is. And again, it just helps you figure out what action to take, because there's no sense in doing any kind of quality improvement or satisfaction survey if you're just going to say, oh yeah, look, it's, that's wonderful, we're great, bye. You need to look at the outliers and always try to be improving. NCQA, any accreditation, any outside organization always wants that, and we should want it ourselves. So again, this is another look at it. This one was an actual satisfaction, so we've got very satisfied, and this is aiming at what they call a Net Promoter Score. I think I've got a slide on that later, so I won't bother. But again, this is real data. This is what it looks like for a real organization providing waiver services. Actually, it's our organization if you really want to know. So another way to get data out of the system is if there are comments, then what it can do a word cloud of those comments. So this was, you know, what could we do for you that's better than we're doing? And you can see that people were pretty happy with the program when you ask sort of a negative question and you get all of these kinds of answers. But it's an interesting way to process text. I always find this, I'd like to look at it. It may not be, you know, completely change my mind, but it's a very useful way to look at data that comes in text and paragraph form. So when I talked about Net Promoter Scores, so we sent an example report to some people on our board, other people that are associated with N4A to have them look at it. And a Net Promoter Score is a standard measure of quality, satisfaction, you know, bragging rights in the healthcare world. And that's the question, would you recommend your care manager, would you recommend this program, would you recommend whatever to a friend or relative? If it's a working population, you might say to a colleague or a family member. You know, the social reference group may change depending on the population. So, you know, seniors who are 85 and older, you'd say friend or relative. The way you compute a Net Promoter Score is you take the top two answers, so that's on a scale of 10, a 10 or a 9. You ignore 8 and 7, and you subtract 6 and below. So Net Promoter means somebody who's so enthusiastic that they're likely to bring up the subject and say, have you heard about this program at MSSP, which is what our California waiver is called? The 7s and 8s and 6s are just never going to mention it. They're satisfied, but they wouldn't be out there. And then all the negatives are going to be out there, you know, dissing you in the world. So 93 to a health plan is unbelievably good. I was looking at some Net Promoter Scores for health plans, and the best health plans are getting like 40%, something like that. As you know, here we got 93%. Of course, you know, the waiver is lots of great free stuff for people that thought they'd wind up in a nursing home and in a generation that tends to be grateful. So, you know, you can't really compare those, but if you say you've got a Net Promoter Score of 93%, they're still going to stand up and take notice. The small print about this survey, because we are going to invite you to participate. We hope that we'll get lots of folks using the survey. It's currently hosted in a secure HIPAA-compliant Survey Gizmo that we pay actually thousands of dollars a year to keep, so that we have this safe environment for hosting data. Partners in Care Foundation is the current host because I was in charge of the committee, and I use Survey Gizmo for everything because I ran our research center, and you know, we had it, so we're hosting it. If that ever created a sense of discomfort and someone thought a different kind of neutral party like a university should host it, we would give it up in a second. So it's not, you know, it's a convenience right now because it's there. And if, you know, anybody had qualms about it, we would hand it off in a minute. Right now, people can request data exports or reports. So those graphs and the word cloud are the reports that are auto-generated by Survey Gizmo. You can also just do an Excel data dump and send that to people so they can play with their own tools. we wouldn't want to do it any more than monthly at this point. And likewise, if you wanted to benchmark your report against everybody else in the world, we wouldn't want to do that any more than monthly. So I think, yeah, and just a note that we do our waiver satisfaction surveys in I think semi-annual batches. We found out in some surveys that there was a correlation between dissatisfaction and a particular case manager, and so we decided that we need to sample all of our case managers' works more frequently so that we didn't go a long time with that kind of dissatisfaction that really needed to be followed up on. At the time we were doing annual surveys, and it was like one of those OMG moments where we said, okay, we have to increase the frequency. But usually people aren't using this on the fly, like every time you close a case you do the satisfaction survey. That's not how this particular survey is used. Our next one up is going to be a care transition survey that's almost done, and that one you would do on the fly, 30 days, 60 days, 90 days after the episode of care was over. And so we provided in this a test link, and so for you to try, you can enter test data. I would not enter real data, not that it's not secure, but it's, it won't count, and we won't be producing reports based on a test link. Beth Blair at N4A will be collecting any requests to use the full survey, and then we'll just have a chat about it, make sure everybody understands and is bought into the right way to do it, and then we'll get you set up on the main satisfaction survey. So to do that, we will need the names of your case managers, the names of the program, so that we can customize the questions. And then we can add questions. So if you look at our questions and say, we've been measuring this for 5 years and we really need to continue asking this question, we can add a question for just your site. And then, of course, you won't be get any benchmark information on it. And then at that point, Beth will send the link to the live survey. Just so you know, a few other products that the Health Plans Work Group is working on. I'm sure that there is or has been already a health systems work group report out in this medium, but because they're doing readiness assessments and all kinds of wonderful tools that folks will, competition analyses and things like that, the same audience, I think, would be interested in. Like I said, we're in the final stage of kind of wordsmithing and getting outside opinions on how important would this question be in convincing you to contract with a community-based organization for care transitions interventions. So that's what we were asking. So I asked one of my board members, and we had chosen a 5-point scale for that Net Promoter Score, but the standard is 10-point scale. So they, we're changing that question to a 10-point scale because we don't want someone to be able to say, you said this was a Net Promoter Score, but it really isn't unless you use a 10-point scale. So we're changing our approach in response to some of the feedback we're getting from healthcare organizations. There are other questions where they, the person said, this question is fine to ask. We don't mind getting this information, but it isn't what we want. We wouldn't deny you a contract if we didn't have this information, but if you're using it for your own internal measurement, quality improvement, or benchmarking, please go right ahead and send it. So so we're getting kind of a prioritization, and if they say something's not very important and we don't really need it for our internal quality measurement, then we reduce the length of the survey, increase the ability of older adults or people that don't have a lot of time to finish the survey and get through it without survey burden. So our care transitions is not just patient experience. We're adding in, all we can do is member-reported, patient-reported outcomes like, have you been in the hospital in the last 30 days? How many times have you been to the emergency room in the last 60 days, whatever it is. A pre-question about, how many days a week do you exercise, and the post-question about how many days a week do you exercise. So we're trying to build the kind of outcomes that people are interested in right into the survey, so that we at least have some data to provide. It may not be the most convincing data in the world, but that's all. And we're also developing standard product descriptions, so that there are more and more national contracts. So if somebody gets a national contract to do care transitions, we've already pre-surveyed CCTP sites. We know what services are included, and we know that if you offer this product, you'll get a national network of folks that can provide it across the country. And I think we've got the Q&A going. So Steve, do I hand it back to you for Q&A, or do I just read the questions?
No, we could do the Q&A here together, Sandy.
Sure.
Yes, it is time for the Q&A portion of this webinar, everyone. So if you have any questions for Sandy, what we've been talking about here, now is the time to send them in. And Sandy, let's get to the questions here. The first question for you: I would like to test the Survey Gizmo with our locally and state-funded case managers. Is this appropriate?
Totally, absolutely. I think you can adopt this just for your own use. One thing, if the data is in our system, we will aggregate it. There's no PHI, person health information, in the system. So anybody that uses it for themselves gets aggregated in, and we'd be happy to report back. But yes, it's very appropriate, any kind of case management program. In fact, one of the first questions is, are you a waiver? Is this a commercial case management program? Is it, Medicare? It has a question to kind of put you into the space of case management and make sure that we understand that.
Okay, thank you. Next question, Sandy. How many organizations are currently using the tools and sharing the data? Well,
the reason for this was because right now it's only 2. What we're trying to do is get more people to buy in and use and share the data. So 2 of us are using it. We're working on the kind of a final, how do we get your 5-year-old data into our system in a meaningful way and get that reported out so that we can get other people involved. So right now that's what it is. So hopefully we're going to get a number of you using it so that we can get this going. Okay.
Okay. What other outreach are you doing to try to get more organizations on board?
We're doing a blog on this after the webinar today, and then N4A is reaching out to their membership, and so we're just hoping that kind of a social media approach spreads this, because we need participants. It doesn't do what it was meant to do unless we get participants. And we've found that anybody that's seen it has said, this is great, go ahead and use it for instead of what I've been doing. Yeah, it's just the beginning right now.
So social media is a big push of what you're trying to do.
Oh, totally.
Okay. Okay, next question here for you, Sandy. This is probably wishful thinking, but did I understand you to say that there is an alternative case manager accreditation than NCQA?
Okay, so yeah, there are others. There's CART, something like that. There's and there's a competitor to NCQA. What I was actually referencing is that NCQA has split case management into home and community-based services, or LTSS, I think they call it, and health plan case management. So one of the differences is cost, and the other is that they've done a translation so that it really is, all of the standards are appropriate to what happens in long-term services and supports. But I can look up, it's just not hitting me that there is another accreditation. So the thing about accreditation is that the people you want to recognize the accreditation have to recognize, you know, that you want them to give you credit for being accredited, so to speak. And so if you get accredited by an agency they've never heard of, I'm not sure it achieves the goal. And I know that NCQA is the most frequently recognized accreditation. In fact, this health plan didn't say we want you to get accredited, they said we want you to get NCQA accreditation. So probably a little bit, yes, a little bit of wishful thinking. But if you want to know more about other accreditations, we can get you that information.
Okay. Next question. Is there a fee to use the satisfaction survey? And second part of the question, can the organization serve persons with IDD instead of the elderly?
The first answer is no fee. We just want the data so that everybody has access to data. And the second is, yes, it's a generic, it is not about older adults. We have no questions about older adults. It's about people that are getting long-term services and supports, which is everyone with cognitive or physical impairments. And one of the questions actually is, who's answering the questions? Is it a caregiver, or is it the client, member, or patient themselves? So it's perfectly appropriate. They're very general questions about, you know, experience and considering my wishes and timeliness and keeping your promises and things like that.
Okay. And what other obligations would there be if we were to participate, such as time?
Time. Well, you would be doing the data entry. So just like you do something, if you have a paper survey, you probably put the results into an Excel spreadsheet. So what this would do is, instead of paper, and let me give you my perspective. We were doing it on paper. Paper takes somebody to, you know, stand at the copy machine, make the copies, fold them, put them in an envelope, address the envelope, pay the postage, send it, remind people, all of that, and then once you get the paper back, you have to transcribe it into some way that you can analyze the data. So what this does is it gives you a link, just like any SurveyMonkey, any survey link. You click on the link, you answer the question. So there are initial questions about what agency are you, and you know which case managers and things like that, and then you just key in the survey questions directly. So we use our call center to call people. Hopefully they recognize our phone number. So you would do the same. So it would be a call from your agency that's providing the services. So hopefully they wouldn't screen you out. So we get a better response rate approaching it this way, and we think it's actually less time, not more time, because the data entry is happening while the survey is being administered. The obligation is to use the survey. There really is no obligation. When you want data, you ask. We do an Excel export or print out the most recent, you give us the dates that you want encompassed in the report, and we'll, that's just sort of a grant-funded free service for now that we'll give people. So you get your reports out of it, and there's no cost. Does that, so yeah, just use, what we want is people to use it.
Next question. Besides care quality and satisfaction, is there financial incentive in contracting with managed care organizations, and how does payment get decided?
Oh, so this is not about the survey, but it's about experience in contracting with health plans. And by the way, there's an October panel on this very webinar. So stay tuned for that. But there is a financial incentive for Medicaid managed care organizations to keep people in the community, absolutely, because what they pay for community-based LTSS is leaps and bounds less than they would pay for a nursing home or an assisted living facility if they're in assisted living waiver. So for LTSS and in Medicaid, keeping people in the community definitely has a financial ROI. There are HEDIS measures that they're judged by, that these surveys, it helps them keep their own accreditation to get these data. If you're doing this under contract with MLTSS and give them the data, then they can report the data, and it helps them maintain their HEDIS measures and that kind of thing. In Medicare Advantage, it's star ratings, and physicians, it's star ratings. So the value proposition for a health plan is attracting new contracts. So we've got this wonderful service, and you should use us instead of this other health plan because we provide this wonderful service. Member retention, so even if everybody doesn't get all of the services, they can retain members because it costs a lot of money for them to have turnover in their members, so they invest in wellness, and then somebody else reaps the benefit in their better health down the road. So they want to attract members, keep members. They want to be able to have their, the ability to report that, the health plans get star ratings. So there was a health plan in LA that had only 3 stars, and they didn't get to participate in the duals plan until they were back up to 3.5 or 4 stars. So that's really important, and satisfaction and patient experience is part of that. Payment gets decided so many ways. We approach it that we try to make sure we know what it costs us to provide a service, which means you've got to know exactly what that service is. You've got to have lots of discussions and plan out your workflows and all of that before figuring out what the payment should be. And then hopefully it's something more than the raw extra cost it would cost per person, and less than, it's got to give them an ROI. And different health plans have different standards. So in some ways we're so small that we're a decimal point to them, and to bother with all of the contracting and legal and the hoops that they have to jump through to have a contract, it's got to be a fairly substantial. So like when I was talking about our UCLA, where we had a population level decrease in readmissions, and in addition the intervention group had a 66% decrease. You can translate that, and I have a little spreadsheet that I use. It's simplistic. It's simple and simplistic, which means you could complicate it with all kinds of other factors, but just to get a an idea of it. You just plunk in the numbers. It's particularly aimed at readmissions. So you plunk in your pre and post readmission rates and the cost and your local cost per readmission, and it gives you an idea of what your ROI is and who you can probably negotiate with. Did I answer question 9 well enough?
Yeah, I think so. Yeah.
Okay.
So, you were just you just mentioned ROIs a couple times in your last response there. So, in general, along the continuum, what kind of a ROI are you looking for that would indicate a a baseline good of what you're looking for, as opposed to something that's a little bit more anemic?
I mean, me as a human being, if I got my money in stocks, 0.1 to 1. But I've had numbers quoted as high as 3 to 1. I would aim at a net ROI, so you've got to net out what it cost. And the problem is we don't know what it costs the healthcare organization, because I'll tell you, for every meeting we have with them, they've got like 5 people on the phone. So they actually do incur a cost. So I would say like 1.5 to 1 would be pretty attractive. 1 to 1, meaning that for every dollar you spend, you net save $1. So that's like 100% interest rate. That's pretty safe. And if they're motivated, so like Providence Health System is trying to reduce their readmission penalties, but they're also a mission-driven organization. So their ROI calculation is a little bit more liberal than a for-profit, super large health plan that can't be bothered with us. So I hate to say it depends, but it does. The scope and that, but I would say no less than 1 to 1, and the financial ROI. But if you put together a case of quality, satisfaction, and mission, then you can probably go with a lot less.
Okay. Sandy, a little bit earlier in the presentation, towards the beginning, there was a slide about the most common healthcare partners for CBOs contracting with healthcare entities, and it was a very helpful graphic there. Did you notice any patterns of why that was structured that way, and why those particular organizations stacked up as the popular, in the descending order as they did?
Because they operate in the long-term services quadrant that we occupy. So the top 2 were Medicaid, and in some states, all of the Medicaid managed care entities are required to contract with, like the area agencies or the equivalent, or some kind of senior services organization. So some of those are, people have contracts because the state required the MCO to have a contract with a community-based organization, but also because they're providing the services that we provide. So we're more of a strange entity to a commercial health plan that has, younger people. They're not doing long-term services. They're not at risk for long-term services and supports. So if you're at risk for paying for a nursing home stay, then that's the number 1 driver of the fact that Medicaid health plans are at the top of the list, and the fact that some of those contracts are mandated, it would also be considered. And then as you go down the list, the hospitals and health systems, because they get penalized, so they've got an out-of-pocket expense now that they're trying to mediate by investing in the services that we provide, care transition services.
Okay. Well, Sandy, we have reached the end of our hour here, and unfortunately we're out of time, but I want to thank you for joining us today for today's webinar. Thank you.
Our pleasure. It's always fun. Thank you.